All right, my presentation is on alcohol withdrawal. The patient is a 42-year-old male brought to the emergency department by his wife via private vehicle for evaluation of nausea, vomiting, and generalized malaise that started yesterday. Additionally, the patient reports palpitations, diaphoresis, shakiness, and increased anxiety that have been progressively worsening over the course of the day. Patient's wife mentions that the patient is a daily drinker for the last 15 years and has been unable to consume any alcohol for the last 24 hours due to nausea and vomiting. Patient admits to consuming a fifth of whiskey and a few tall boys daily up until yesterday. He denies prior history of withdrawal, seizures, or delirium tremens. His chief complaint is nausea and vomiting. His associated symptoms are generalized malaise, palpitations, diaphoresis, tremors, and increased anxiety. He denies any known medical problems, but notes that he has not seen a doctor in 20 years. He does not take any medications regularly at home. His physical exam reveals a heart rate of 122 beats per minute, a respiratory rate of 24, a blood pressure of 182/99, and a temperature of 98.2. He appears anxious. His skin is diaphoretic and appears flushed. His pupils are equal, round, and reactive to light. His extraocular movements are intact, and he has no scleral icterus. His oral mucosas are dry. His neck is supple. His trachea is midline. He is alert and oriented ×4 to person, place, time, and situation. His cranial nerves 2 through 12 are intact, and he has no focal neurological deficits. His abdomen is soft, non-tender, and non-distended. His bowel sounds are active in all four quadrants. He has no rebound or guarding, and he has no palpable organomegaly. His heart sounds are normal S1 and S2, but tachycardic with irregular rhythm. His cardiac monitor reveals sinus tachycardia with occasional premature ventricular contractions. His lungs are clear to auscultation, and his respirations are even and non-labored. Alcohol withdrawal happens when someone suddenly stops or significantly reduces their alcohol intake after prolonged consumption. Alcohol works as a central nervous system depressant by inhibiting the excitatory glutamate receptors and enhancing the inhibitory GABA receptors. When alcohol consumption stops, the CNS is no longer depressed and the body experiences an excitatory overload due to the removal of inhibition, resulting in withdrawal symptoms. Symptoms typically begin within 6 hours after the person stops drinking. Withdrawal seizures are generalized tonic-clonic convulsions that typically occur within 12 to 48 hours after the last drink, occur mostly in patients with a long history of a heavy alcohol use, and progress to delirium tremens in nearly one-third of patients if left untreated. DT is a condition characterized by various symptoms such as hallucinations, disorientation, tachycardia, hypertension, hyperthermia, agitation, and diaphoresis that occur after an acute reduction or abstinence from alcohol, generally within the first 48 to 96 hours of the last drink. Assessment for a patient in acute alcohol withdrawal should include a comprehensive substance use evaluation that assesses for recent use, last use, and previous treatment history, a thorough physical examination, laboratory testing, and serial monitoring of the withdrawal severity using CWA. Timing of withdrawal symptoms. Within the first 6 to 36 hours after the last drink, the patient may experience minor withdrawal symptoms that include tremulousness, anxiety, headache, diaphoresis, palpitations, and a normal mental status. 6 to 48 hours after the last drink, the patient may experience seizures that are characterized by generalized tonic-clonic seizures with short postictal periods. 12 to 48 hours after the last drink, the patient may experience alcoholic hallucinosis, which is characterized by visual, auditory, and/or tactile hallucinations with intact orientation and normal vital signs. The normal vital signs and intact orientation are what distinguish alcoholic hallucinosis from delirium tremens, which can onset 48 to 96 hours after the last drink and is characterized by delirium, agitation, tachycardia, hypertension, fever, and diaphoresis. Diagnosis of alcohol withdrawal can be made using the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, or DSM-5 criteria. This criteria includes, firstly, cessation or reduction in alcohol use that has been heavy and prolonged. 2 or more of the following symptoms developing within several hours to a few days after the last drink: autonomic hyperactivity, increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, anxiety, and generalized tonic-clonic seizures. These signs or symptoms must cause clinically significant distress or impairment in social, occupation, or other important areas and should not be attributable to another medical condition or mental disorder. Laboratory testing for a patient in acute alcohol withdrawal should include a CBC, serum electrolytes including potassium, magnesium, and phosphate, glucose, creatinine, liver function tests, amylase and lipase, a blood alcohol level, urine drug screen to assess for the presence of benzodiazepines, cocaine, and opiates, and a urine HCG for premenopausal women. Other testing for these patients should include an electrocardiogram for patients over the age of 50, or if there is a history of or concern for cardiac problems, and a head CT to rule out contributing or alternative pathology for patients who had a first seizure or who are experiencing mental status changes. The CWA scale is most studied and most widely used scale to assess severity of alcohol withdrawal. It should not be used to diagnose alcohol withdrawal. Rather, it should be used to guide symptom-triggered management, which has been shown to reduce the total amount of benzodiazepines needed and to shorten the duration of treatment when compared to a traditional fixed dosage regimen. This is an example of a CWA protocol. There are multiple components, including nausea, vomiting, tremors, anxiety, agitation, paroxysmal sweats, orientation, tactile disturbances, auditory disturbances, visual disturbances, and a headache. These components are scored on a scale of 0 to 7 and are also obtained with a full set of vital signs, including pulse, respiratory rate, oxygen saturation, and blood pressure. Scores of 0 to 9 indicate absent or minimal withdrawal. 10 to 19 indicate mild to moderate withdrawal. And scores of greater than 20 indicate severe withdrawal. Medication administration is then determined based on this score. Benzodiazepines are used to treat the psychomotor agitation and to prevent progression of minor withdrawal symptoms to major withdrawal symptoms, seizures, and DT through the stimulation of GABA receptors, which cause a decrease in neuronal activity and relative sedation. Valium, Ativan, and Librium are used to treat alcohol withdrawal, but other benzodiazepines can also be used, such as Serax. In most cases, long-acting benzodiazepines with active metabolites such as diazepam and Librium are preferred because they have been shown to have a less complicated clinical course and reduce the incidence of recurrent withdrawal or seizures. In patients with advanced cirrhosis or acute alcohol hepatitis, Ativan or Serax are preferred because of their shorter half-life and lower risk of oversedation. Phenobarbital can also be effective when given as an adjunct with benzodiazepines because benzodiazepines increase the frequency of GABA chloride channel opening, while phenobarbital increases the duration of how long these channels are open. Anticonvulsants, including carbamazepine, gabapentin, and valproic acid or Depakote, can be used in the outpatient setting to manage mild alcohol withdrawal, but there is limited evidence to prove their efficacy for treatment of patients with delirium tremens or other severe symptoms in the hospital setting. Providers should also treat electrolyte abnormalities and administer thiamine to prevent Wernicke's encephalopathy. Librium. 25 to 100 milligrams of Librium can be administered orally for patients with CWA scores of greater than 8. It is a long-acting benzodiazepine. It acts by binding to benzodiazepine receptors on the postsynaptic GABA neuron sites within the CNS. This causes enhancement of the inhibitory effect of GABA on neuronal excitability by increasing neuronal membrane permeability to chloride ions, causing a shift in chloride ions, hyperpolarization, and stabilization. It may cause CNS depression, which can impair physical or mental abilities, and it's a substrate of CYP3A4. So drugs that also use this pathway can enhance CNS depression, such as alcohol and other benzodiazepines. Valium can be 5 to 10 milligrams of IV Valium can be administered for CWA scores of greater than 8. It is also a long-acting benzodiazepine and works by binding to benzodiazepine receptors on the postsynaptic GABA neuron in the CNS. It's a substrate of CYP1A2, CYP2B6, CYP2C9, and CYP3A4. It can cause anterograde amnesia, CNS depression, and concomitant use with opiates should be avoided because of the risk of profound sedation, respiratory depression, coma, and death. Lorazepam, 2 to 4 milligrams of lorazepam can be given for CWA scores of greater than 8. It's a short to intermediate acting benzodiazepine. It binds to benzodiazepine receptors on the postsynaptic GABA neurons within the CNS, just like Librium and Valium. The most common adverse reactions are pain at the injection site if given IV or IM, and nervous system symptoms such as drowsiness and a sedated state. Like diazepam, concomitant use with opiates should be avoided, and it should be used in caution for patients at risk of falls and in older adults. Patients should be counseled on risk for dependence and monitored for signs and symptoms of abuse, misuse, and substance use disorder. This is especially relevant for patients in acute alcohol withdrawal. Phenobarbital. Phenobarbital should not be used as a monotherapy for management of acute alcohol withdrawal, but it can be given for refractory delirium tremens or as an adjunct to benzodiazepine. 130 to 260 milligrams IV in 15-minute intervals can be administered for refractory delirium tremens. Doses of greater than 15 milligrams per kilogram in the first 24 hours are not recommended, and maintenance dosing should be decreased to 130 to 260 milligrams IV total per day once withdrawal symptoms are well controlled. It is a long-acting barbiturate with sedative, hypnotic, and anti-seizure effects. It depresses the sensory cortex, decreases motor activity, and alters cerebellar function. It's a minor substrate of CYP2C19, minor substrate of CYP2C9, and a minor substrate of CYP2E1. It induces CYP1A2 weekly, CYP2B6 weekly, but it strongly induces CYP3A4. The most common adverse reactions include hypotension, sedation, and respiratory insufficiency. Barbiturates produce dose-dependent respiratory depression. They should not be discontinued abruptly, and therapy should be withdrawn gradually to prevent increased risk of seizures. This patient is likely in acute alcohol withdrawal based on the history and symptoms provided. The provider for this patient ordered laboratory studies, including a CMP, CBC, lipase, ethanol level, and urine drug screen to assess for other causes, treat potential electrolyte abnormalities, and determine the appropriate clinical course. On his labs, the patient had normal hepatic function as evidenced by a normal AST and ALT, so the provider ordered IV diazepam to be administered using a symptom-triggered approach with the CWA scale. The patient was also given a multivitamin, folic acid, and thiamine supplementation to prevent Wernicke's encephalopathy and other complications. Ultimately, this patient was admitted to the acute telemetry floor for detoxification from alcohol and to monitor for worsening withdrawal. In summary, benzodiazepines are the drug of choice for management of acute alcohol withdrawal. A symptom-triggered approach using scales such as CWA have been shown to reduce cumulative benzodiazepine doses and duration of withdrawal compared to a traditional fixed dosage regimen. Refractory DT should be managed with phenobarbital or adjuvant antipsychotics. Electrolytes should be monitored and supplemented accordingly, and thiamine should also be administered to prevent Wernicke's encephalopathy. These are my references. Thank you.